Good morning, everyone. Good morning, Alan. Sunday morning. And we are going to talk about something near and dear to our hearts. So hopefully, our passion will not make this a 3 hour talk, but we are both long-term, passionate primary care physicians. We truly believe in the ethos of primary care, which is not simply to fix people's numbers but to have a relationship with our patients such that we know them, understand them, also understand the data and how it applies to every human being sitting in front of us, understand the patients get to make their own decisions, that we should promote lifestyle and try to get them to be as healthy as possible by their own motivations. And there are a lot of barriers to that. And in our careers, and especially in the last 10 years, I would say, we've seen a total erosion of the system's willingness to accept that very model of care, and pushing us into a model of referral doctors. And in fact, more and more nurse practitioners coming in to take our role, which is fine to an extent, but many of them are owned by corporations or doing the bidding of corporations or doing the bidding of hospital systems that seek referrals to their own specialists. So they're willing to pay them more actually, just because they're referring. So I looked at I have very passionate patients also who believe in lifestyle and believe in primary care and are furious with the system. One of them brought me, she was having some gastric problems and went to a gastroenterologist and was told that she has to talk to this nurse educator. And this woman knows nutrition better than anyone, not the educator, my patient. But the educator tried to tell her a couple things on nutrition that were just wrong and talked to her for 5 minutes. What upset my patient, she brought in the Medicare EOB. This is the statement of payments that were made to Medicare. My visit was there and how much I got paid. And we spent a good 35, 40 minutes talking about a lot of things, her stresses in life, her medical problems, her nutrition. Below her was this nurse visit, which was 5 minutes, and the nurse visit paid substantially more than my visit. But and we have to talk about that, Alan. But the second thing we have to talk about, and then I'll get off, is that primary care under its current model is not only not sustainable, but not as effective as it could be. I recently had a friend who went to a primary care doctor. This guy was old. He was falling, fainting, couldn't walk. He was on three blood pressure medicines, a statin. Um, and it was clear as I talked to him, the blood pressure was very low at times. And this primary care doctor said, well, we can't touch those blood pressure medicines. We'll have to send you to a cardiologist, and I'm going to send you to a neurologist. We've already had blood work done a couple months ago, so we're not going to do that. And that's the end of the visit. Never asked questions about the history, never asked about how much he's drinking and whether there are stresses in his life. That was a 15-minute visit. And we have to also face the issue that, yes, and Alan's passionate about this, about having a primary care doctor for all Americans, but we just can't have that kind of primary care doctor. We have to figure out both angles here.
Sure. So Andy, my response to you would actually take an hour to what you brought up because now my heart rate is going because you really touched on a lot of the points. But there's a lot of evidence and a lot of facts. If you read our book, we go through a return to healing, kind of the history of medicine and how we got here and the simple fix. And the simple fix really is primary care, and it would be a very inexpensive fix because the data out there is overwhelming. In fact, in medicine, the only kind of field of medicine that has ever been shown to make a difference in people's lives, and I'm talking about in chronic care models, not acute, I can't save you if you get shot in the heart. I'll try, but you want a good trauma surgeon there, and if you're truly having a heart attack or a stroke, we want an interventionalist there. We know those things help, okay? But we know we could prevent them. And we know certain simple things about what it means to have a primary care provider. And when we talk about primary care provider, like Andy said, it's got to be the right one. We'll talk about some stories of not right ones. But the right one who gives you true whole person advanced primary health care that looks at the whole picture is going to guide you in a way that's going to help you live a happier, healthier, better life at lower costs. We know when those people have a primary care provider, their hospitalizations are 20% or more less, their ER visits are 20% or more or less, their satisfaction with the healthcare system is higher. They see specialists less. And we'll talk about specialists NPs because I think you brought up really important points there because they're our friends and colleagues too, but there are statistics that show their movements go in a little bit different way. And when you look at all that, only 5% of the healthcare dollar is spent on primary care. And if we increase that spend, and to be honest, if we took 5% out of the highest paid portions of medicine, not just doctors, I'm not saying take money away from the cardiologists, things like that, but if we took 5% or 10% away from these high cost procedures, do you really need to make, $75,000 on a knee replacement? If you made 74,000 and put 1,000 of that into primary care, we could make the world a better place. Only 5% of the healthcare dollar. It's literally absurd when you look at it and people don't see these facts and people don't see the facts of how simple it would be. The problem is the change that we're asking for is going to totally upheave the medical industrial complex because we're going to save money and nobody wants to save money. The hospital executives don't want us to save money because they want people coming in and getting procedures. The drug companies don't want us to prescribe less drugs. They want to make more money. Okay. The insurance industry wants to make more money. The professional medical colleges and the patient-centered, advisory groups want more money spent because that's money that's coming to all of these organizations. It's going into their salaries. It's increasing the cost of healthcare, and it's making us all sicker and poorer. Profits over patients, and we need to change that. How we're going to do it is really tough, but the answer is really simple. So I'll shut up and go back to you for a bit.
No, it is simple, and it's interesting that even in the last few years, there have been attempts to say we're going to take 1% away from the highest paid procedural specialists, and their lobbies go into Congress and knock it down. And their lobbies are so strong. No one really sees that side of medicine. We don't have a lobby, Alan. There's no one fighting for us, and that may be our biggest mistake. But the Congress controls what Medicare will give to each doctor, and every other insurance kind of follows the Medicare train in that way. And this has been the way it is for a while. So Congress can be easily influenced, and these people come in, these lobbyists, they pay a lot of money for elections, and they also give a line that says, you stop paying money for this much money for stents. We have a statistic that 72,000 people are going to die next year. They just make stuff up, and it's very easy to do. We've talked about that a lot, how you can make up statistics. Bottom line, good primary care saves money, like Alan says, but it saves money that goes into people's pockets. And so they're gonna push back really hard. Patients love a nice half-hour visit with a doctor they know. They look forward to that visit. They could grapple with real problems. A doctor who says, "Yeah, I know the cardiologist said this, but let me give you a counter narrative to that," and you make a decision. They love doctors like that. They flock to them, and it would be not just save money, but create healthier people, more invested in the healthcare system that they respect, which they don't right now, because our healthcare system is more that primary care doctor I talked about, or another primary care doctor who's in my town who um, orders a whole bunch of labs that are meaningless and owns a vitamin store on top of his office, and just sends people to his store to buy vitamins he has reproduced under his name, and says this will save your life. And that's where he makes his money. We could go on and on about stories about primary care doctors who are trying desperately to stay afloat because if they just do seeing patients and helping them, they're going to make less money than that nurse who works in the GI office. So hence some have gone to the concierge model where they charge their patients $2,000 to $3,000 a year, and they can spend time and have fewer patients and richer patients who generally are people less difficult to take care of because they have the resources to do everything. So yeah, we're resorting a lot. The few primary, no one's going into primary care. And Alan could talk about that more fully, but I had two kids who completed medical school, and nobody went into primary care. Nobody went into primary care from internal medicine residency, which is shocking. In my residency, 50% of people went into primary care. So that's one thing. And number two, because of the low pay, primary care doctors, the few who go in, are finding other ways to make money, which often is not the best way to take care of patients in a relationship way, like Alan and I have been doing. But we are the dinosaurs. We're almost extinct.
Yeah. So, my son as well, I thought he was going to join my practice. I never pushed him. I never pushed him to be a doctor. Didn't think any of them would be. And my son wants to be a trauma surgeon. And when I said, what made you not want to go into primary care like me? And he said, Dad, you work too hard. Like, you're working 7 days a week. People are calling you at 2 in the morning and 3 in the morning. I want to have a shift at work. I want to go in. I'll work hard. I'll study hard, take good care of my patients. And when I leave, I want to be off. And you can't blame people. Especially, Andy brought it up. We're amongst the lowest paid of all the medical specialties, and it's hard for doctors to make a living in primary care if you're going to be the old-fashioned, Marcus Welby, MD kind of person. It's hard to make a living. And that's why it's hard to find a primary care doctor. They've shown it in things like Andy said, direct primary care and concierge medicine. If you live in a wealthy community that could afford to pay you per member per month, you could see a lot less patients and make a lot more money. And some of the young people are marketing themselves and going into it and making a good living. But they're not making a good living by being a bad primary care doctor. They're actually making a good living by being a good primary care doctor.
Right.
They're keeping their patient panels low. They're only doing things for patients who need it, not to them, for them to make money, because they're not going to make any more money by doing testing and more drugs and more procedures. They're actually making more money and having happier patients by keeping them happy and healthy and out of the hospital. So that model does work for people that have money. If Medicare and Medicaid, for the poor and elderly came up with a similar model, I think that might add to the shift in healthcare as well, especially if we found a way to fund health insurance for all of us. But, as Andy said, there are bad primary care doctors out there as well. I shared a video with Andy this week that one of my learnees sent me, former residents in my program, about this primary care provider that's advertising in New York. And it was like a 2-minute TikTok video that's out there where she talks about the excellent care that they give because before you even see the doctor, you get extensive comprehensive blood work, much more than any doctor would do. And then you get an EKG and a pulmonary function test, and then you get a vascular test of every part of your body, your head, your neck, your abdomen. You get cardiac testing, you get GI testing, you get all of these things done. It was about like 25 or 30 procedures, none of which have been shown to improve health or longevity. In fact, we know like there's no such thing as a routine EKG. Like you're not going to pick up anything by finding it. You pick things up by speaking to patients and asking patients about their symptoms. And then you go in that way. So we need a system that invests in primary care that improves the income of the primary care physician. Let me just go back for 1 second because we did this once before in history. For those of us that are a little older like me and Andy, it was in the 1990s and it was called the managed care movement. This was the early development of these managed care companies where they paid doctors per member per month. And now you were getting paid not to see patients. And many of the doctors loved it. Okay. And you got penalized if you sent someone to the hospital or to a specialist. So it kind of incentivized doctors to give poor care. And it got all the specialists very angry because no one could come see them without a referral from their primary care doctor. So the patients revolted, the cardiologists revolted, the insurance companies ended up revolting because everybody went against them and the model kind of died. And they've tried to make an evolution of that over the years and never quite succeeded in the mess that they made in the 90s. So instead of being practical instead of everyone having a primary care provider and paying them to do it, which would lower the costs of healthcare and meet the quintuple aim of healthcare. We talk about the quintuple aim of healthcare. It's better health, good, lower cost, good, happier patients, happier providers, and equity for all, like everyone has access. That's what we're looking for, and that aim is really easy to accomplish in a simple way.
And we talk about it in the book. Alan and I also wrote an article in Health Affairs several years ago where we looked at various models, and we came to the conclusion economically and in terms of what we can do to promote what we call relationship good primary care is a direct primary care model, is a concierge model where we would see fewer, lower patient panel, and that amount of money per patient, which would be higher for complex patients, like a 20-year-old would not be paid the same per year. We wouldn't be paid the same as a complex 85-year-old or someone who is very poor and is working three jobs and has a lot of chronic illness. Um, and we advocated paying that being the payment model for all primary care from insurance, not people paying themselves. And that would actually save the system a tremendous amount of money. But if you can now recruit good people into primary care because now they can make a decent living, um, not the same as specialists, but certainly at least in their ball, certainly more than their nurses, which we're not doing right now. More people would go into primary care because they know they have more time. They could think, they could have relationships. That's what most people want when they go to medical school. So they would be able to do that. The danger of that is how it would impact all the other rungs of the medical industrial complex. And yeah, so the irony, Alan, I find this really disturbingly funny, is when you listen to politicians talk, when you listen to healthcare leaders talk, they all say the same thing. They know the statistics about primary care. So they say we have to really invest in the primary care system. So, like one of the hospital systems near me, who owns a lot of hospitals, that owns a lot of hospitals, they said we have to invest in primary care. So they created these clinics of nurse practitioners um, who refer everyone to their people. Because in my community, there are four hospitals fighting for patients. So if each one has a big institution with nurse practitioners that can feed people to their specialists, they're going to have a leg up. And at the same time, they say, you see, we're invested in primary care. So no one is investing in the kind of primary care we're talking about. It is easy. That fix we talk about. And also Medicare has full control over residency admissions and who goes into what specialty. They actually pay residency programs hundreds of thousands of dollars per person who goes through residency. All they have to do is say, well, we're shifting and we're going to train a lot more primary care people and a lot fewer specialists for the next 5 years. That's what we need in the system. And at the same time, change to this kind of model, you're going to see a complete, I would estimate, Alan, that we drop back down a couple $1 trillion in the cost of
Absolutely.
healthcare, and our longevity would increase and chronic illness would go down. Lots of studies have shown that's exactly what would happen. That kind of dramatic shift takes a tiny investment, which would actually save money. So why it doesn't happen is clearly because the medical industrial complex, the specialists, the insurance companies, the hospitals, the pharmaceuticals, all are so powerful that they've convinced people, even the public, even especially politicians, that we can't do that. And that's the barrier.
So you just got me even more pissed off. So
I-
the, we'll have to have a podcast on how medical education is funded in this country because it's simply an absurd system that perpetuates this specialty way of doing things. And working on how it's funded would greatly change how the system works, but it would take us 5 hours to explain that right now. So I'll deviate and go back to some of Andy's things. Yeah, look, I have friends that are nurse practitioners. I have nurse practitioners that work with me and for me in the hospital and in my faculty practice, and Andy does as well. So we love these people, but my nurse practitioner works under me, the people that work for me. And I review every one of their charts. I ensure the care that was given, and I make sure they're not over referring, over testing, over medicating, because that's what the statistics show. And again, you look up the statistics. It's simple. You could go on AI now and see that, you know, patients who see nurse practitioners and specialists, their costs are higher and their level of care is not better. We might get shot now for that statement, but it's simply a
That's
fact.
really true.
It,
That's
it,
not even a
it, it,
controversial thing.
it is a fact. So, we can't get in trouble for, well, we do get in trouble for facts if people don't like the
Yeah,
facts that we're
we do.
saying because it goes against what many of the people want. Nurse practitioners by law, I know it's a little different in each state. In New York, me and Andy, it took us 12 years after high school to become the physicians that we are. 12 years of clinical training in undergraduate, medical school, and residency training. And even after we got out, we were junior schmucks in the pipeline there. Nurse practitioners truly only need 600 hours of clinical training in New York to practice. 600. That's my estimate is 3 months of training. And it doesn't specifically say what it is. They could do 3 months of training in pathology, psychiatry, and podiatry, and they're nurse practitioners in primary care. It makes no sense. And we see the increased levels of referral. We need a system. It's like the spoke in the wheel. Family doc needs to be in the center of that, along with the patients. And then we need to refer out to specialists when needed and use pharmaceutical agents when needed and testing when needed and hospitals when needed. We do need all of those other systems. But the system can't be controlled by the medical industrial complex, which is a profit-driven system. They're there to make money. We're there to deliver good care. Yes, we want to make a good living. Of course, we're not idiots. But the foundation has to be embedded into primary care. We know that when those have the primary care physician, we meet the quintuple aim of healthcare. When they don't, more hospitals, more ER visits, more testing, more procedures. And that's what happens when people see specialists. That's what happens when people see nurse practitioners. And yes, we need them. They are there to deliver care when it's necessary. But they shouldn't be caring for hypertensive patients that do vascular testing on every patient and an annual stress test and an annual echo. None of these tests have been shown to be any benefit. Cardiac caths, you've heard us say it probably 1,000 times on these podcasts, have only been shown to be beneficial if you're having a heart attack, period. We need to go back to sensible medicine that is centered around the patient, that is embedded in the foundation of primary care, and that is embedded in the foundation of wellness and health and prevention, not tracing and treating chronic complex illnesses.
And yeah, we should get paid as primary care providers to have a relationship with our patients because that's the most valuable thing that can save money and extend life. And I will say that I'm going to be bold enough to say that all the things you talked about, all those vascular studies, getting an EKG before you see the patient, are shown to actually lower your lifespan. It's in even things like the U.S. Preventive Service Task Force, getting an EKG blindly will lead to more death than if you didn't get the EKG. They give it an F, which is more harm than good. Getting stress tests, doing stents, all those things will lower your lifespan. Why we have the lowest lifespan in the world of industrialized countries is because we eat terribly and don't exercise, and that's something doctors refuse to talk about because they only have their 15 minutes. The primary care doctor I talked about is just as dangerous as a group of nurse practitioners who are or paid by a hospital system. Remember, if a hospital system is paying the nurse practitioners, it's not the nurse practitioner's problem. They're being paid by people who, when they have their little annual meeting, it's, well, you didn't refer enough people to our specialists. We need you to refer more people to our specialists. Their incentive is not patient care. Their incentive is referrals. This doctor who had 15 minutes with a patient, because that's what the system allows if you're going to not have gimmicks. Now, Alan and I have figured out ways around that. And those ways for me are very low overhead. And we do a lot of stuff on our own. And that's the biggest way we can do half hour visits. But if you have a 15-minute visit, you're not going to get to know the patient. You're going to refer to everyone because not because someone's telling you to, but because it's easier and you'll justify it by saying, look, yeah, your blood pressure is 130, you need to see a cardiologist. That's too high. Even though you're falling on the floor and not thinking about what the cardiologist might do and say, well, we have protocols and we have to get you below 120. You're not taking care of the patient. So the system that employs people or that allows doctors to work in a primary care environment is encouraging them to be bad. And
Absolutely.
that's the problem. But we could go back 10 years and it wasn't this bad. And the nurse practitioners work with me. And by the way, they're like at this point, I think nine. Um, they know how I practice, and they actually really were trained to practice this way, to not refer to take care of people in a nursing kind of way. We do geriatrics, so they have this nursing view of sitting down and talking to you and learning about you. But in the real world, nurse practitioners are being hired by corporations not to do any of that. And you talk about the amount of training they need. It's interesting because I'm looking in my old age to get a degree in what's called battle acupuncture, which is basically
I'm
acupuncture.
trained in that, Andy.
What, are you training that?
Yeah.
So I just think it's a good part of wellness. It's something else I can offer. Well, my state requires, you ready for this, Alan? 250 hours of education to get to do any kind of battle
Oh
acupuncture.
my God.
250 hours. There's a course up in Boston that will give me 300 hours. But you're telling me nurse practitioners have about that much just for their full training, right? And that's what I need just to do this battle acupuncture, and I'm going to. So yeah, we have probably thousands of hours of training that we've had to do, and we continue to have to do. And Alan and I both have degrees beyond just the primary care, and I'm wound certified, and I'm certified in long-term care, and I'm getting certified in lifestyle medicine, and Alan's palliative care, and probably 20 other things because Alan is certified, and I didn't even know about the acupuncture. We continue to learn to try to get better and to work on ways that we can help our patients stay healthy. I'm a certified nutrition educator. I just recertified in that last weekend. The book was 1,000 pages long. So we're constantly trying to learn. These other primary care doctors I know are not. They are seeing 30 patients, 35 patients a day in 15-minute intervals, come home, have to write their notes, make phone calls, get back to people. Now it's portals, not phone calls. But regardless, it's a brutal job. And if they get to know their patient too much and learn about all their stresses, they don't have the time for that. And so they don't. I'm not saying they don't want to. They just don't have the time. They don't want to ask any questions because then there might be an answer that they have to deal with. So a lot of the ones in my town, they're machines, referral machines, because that's by reality. They don't want to be. So we do have to change the nature of primary care. That will allow more people to go into primary care. The incomes will be higher. We just want to be higher than the nurses from the gastroenterology office. We're not looking to be, we think a lot of doctors are overpaid because they get incentivized to do all the things that are wrong. They get incentivized to put stents in and stress tests and do all these EMG tests on people to look at their nerve velocity and high-paying tests, dermatologists to biopsy everything that they see. They're incentivized to do that. So we ask in our book, get rid of those incentives for procedures, and put more emphasis on the actual patient-doctor relationship, and pay for that more than procedures, and take away the ability of specialists to self-refer. You go to a cardiologist and they say, yeah, we think you need a stress test, an echocardiogram, carotid ultrasounds. And what they don't tell you is, and we own all the machines and we get paid a lot of money every time you get one of those tests. We don't have that. We don't
Yeah.
get paid when people do anything or don't do anything. Um, we get paid only to have a visit. And that visit should be a good visit where we get to spend some time with people we know. And, that's most people would say, yeah, duh, that's obvious. But what we're trying to explain here is the system completely destroys that possibility. And that's the problem that we have to fix. We put the fix in. The fix in our book is about this long. It's so easy.
It's
It's a
easy. And look,
problem.
we don't claim that we could fix everything. We know what makes health. Andy and I know it very well. We're very holistic physicians, very much into lifestyle and integrative. We know that, your genetics are hugely important and should actually guide your healthcare, your genetics. We need to know our patients' histories, and you have to take your patients' histories to know that. You need to know about their lifestyle. Need to know about their social situations, their access to healthy food, their access to being able to exercise and go out in the communities because where they live. And we know that, the country needs to change. Like we don't invest in wellness and health. We know that an air conditioner in someone who can't afford one, who's an asthmatic, giving them a $200 air conditioner could save 5 hospitalizations a year. So give them a freaking air conditioner to keep them out of the ER. But that's not good medicine because you're not making enough money on doing these things. So we need to change, those health related social needs that are so important. And me and Andy talk about these in every visit with our patients, our elderly patients, our young patients. And you think the cardiologist asked the patients if they could afford the medicine they're prescribing, this new drug, and, putting people on the first visit, they get a new patient with congestive heart failure. The congestive heart failure cocktail of medicines is now like 6 or 7. I've seen cardiologists literally start these 6 or 7 medicines in one visit. Well, that's the standard of care. You have heart failure, you need these 6 drugs. Like, how do you start 6 drugs on a little old lady or even a young man at one time because he has some heart failure? There's just no common sense out there in the system. So there needs to be general changes in the way the healthcare system is delivered. We know that primary care is the answer, is the foundation, but we need to fix the specialty things. And the whole self-referral thing that you brought up, like that's what really upsets me. I should be making the decision, and if my patient needs a cardiac cath, okay, not the person who's going to make, $25,000 doing that cardiac cath and putting in a useless stent that's, probably not needed. It's just a quap. It's how does this continue to go? It's so non-commonsensical. I don't know what the right word for non-commonsensical is, Andy. Help me here. It's
A comments. Well, and you say, and my
well, it's
last
really
thing
effed up, but we're not allowed to say that.
it
So.
is. But my last word, because I know we could talk about this forever, is Alan did bring up, the period of time. It was actually under Nixon. You read more and more about Nixon. Like he did some, he tried in some ways. The Clean Water Act, and he also tried to say, look, we're spending too much money. Specialists are self-referring. And all the primary care has to be the bedrock of everything. And that was the origin of the HMO movement, which was a way to prevent socialized medicine, i.e., government takeover, is that we're going to require everything to go through primary care. And the pushback, the advertisements by specialists who no longer could self-refer, by the drug companies who are going to get less medicine because we prescribe a lot less medicine. We certainly don't give 6 on one visit. Most people get away with 2 old medicines and do just fine in congestive heart failure. We the pushback destroyed the whole movement. So now under the current system of value-based care, I get dinged for the tests the cardiologist does.
Yeah.
Uh, uh, you
Well, it's
know,
total
I,
cost.
it's the total cost of care. And I said, well, what if they decide to go to a cardiologist and they get all this unnecessary care? They said, well, you shouldn't send them to the cardiologist. I said, but I don't send them. They go on their own to the cardiologist. I have no control of this. And the cardiologist gets paid for all these tests, and I'm the one who gets dinged. So that's our
Yeah.
current model of value-based care. It's the most absurd thing I've ever seen in my life. And if you take care of unwell patients who have no resources, who have to go to the emergency room, you get dinged for that too. So you're better off taking care of rich people. It's just a system now that is making us the victims of the bad system rather than the people self-referring. So
So
that's
you hit the
disturbing to me. And yeah, we need to set. I hope COVID. I hoped COVID would open people's eyes, and I think a lot of people's eyes are open. Not the media, but I keep reading things from normal people who say they don't trust any doctors anymore. And honestly, that's
And
not
I don't blame them.
what should be what, but that's how it's going to start, right? It's going to start, and because those same people would love a primary care provider who sits and talks to them and understands them, doesn't push them to do things they don't want to do, and tries to help them live a better, healthier life within the bounds of what they're able and want to do. And that's just common sense. And yeah. So I'm not super hopeful, Alan. But maybe if people start really distrusting the system, they will push back because any change has got to come from patients, not
Yeah,
from
well,
us.
well, we could go on forever. I need to come back to you at a couple of these things. One of the problems is, some people don't know the importance of having a primary care doctor, especially more educated, affluent people who think, if I have two ticks in my chest, I need to see a cardiologist. And they're going to do a lot of tests, and that's good. So people think this is good. And then the cardiologist can't find what's wrong with them. And they say, send them to their internist buddy, the gastroenterologist, who can't find what's wrong, who then sends to someone else. And, they end up, at a mental health practitioner. And we could have, prevented that in the beginning. We don't have a healthcare system in this country. We have a sick care system that is led by the medical industrial complex, which is made for profits over patients. And until that mindset is shifted, things are not going to get better. The simple answer is whole person primary care, patient centered with the patient at the center, and a primary care doctor or good clinician, not the bad ones, as their partners in their healthcare, one that is based on forming relationships, trust, communication. That's what makes people better, and it's the simple fix. And we could get there, but we have an army of people against us in primary care who don't want to see us succeed, because if we succeed, we're going to save money to the healthcare system, and that is going to hurt the profits of the medical industrial complex.
And yeah, and that army of people is not just against primary care, it's against patients living
Yep.
healthier, longer lives too. Because that doesn't help them one bit. If they stay out of the hospital, stay away from specialists, stay away from drugs, and live a healthy life because they're eating well and have a relationship. Just having a relationship with a doctor like Alan and I and so many others who try hard is going to make them happier and more invested in the healthcare system and more willing to do things for their own health because we're not pushing them. And we read and we understand, and we're the Oslerian doctors who truly understand the science of medicine, not the way the drug companies and specialists portray it. And we understand how to apply that science to the individual sitting in front of us, rather than just having a checklist or a calculator or a computer, which doesn't work because we're dealing with human beings who are complex emotionally and physically and socioeconomically, and we understand that, and that is, people go into health medicine to become doctors, all have the capacity to become doctors like that, and they are immediately pushed away. And then we will, Alan, have a talk about medical education because I think it's good for people to understand how the system, right from day one, or even before you get to medical school, starts to corrupt you and try to make you into something that is not probably what you wanted to be when you said, I want to be a doctor when I was growing up. So that's
Yeah, I
my
don't.
last word, and you could give a last word too.
Okay, so I don't think that woman in the TikTok video, the doctor, meant to be a bad doctor. She's unfortunately trying to make a living in this, horrible world. It's not the way it should be, and we really are at a crisis situation. It's partially it's because of the trillions of dollars we're spending on healthcare, which is not sustainable. It would be sustainable if we were having a healthier outcomes from it, which we don't. And my fear is that, AI and robots are going to take over, and healthcare is going to just get worse and worse and worse until these AI and robots just kill us all,
You mean
which
you mean
is,
electronic robots, not the human robots we have now?
yeah, yeah. So, I'm scared of that. And, I think me and Andy are becoming dinosaurs, and I have medical evidence to prove it, because one of my patients last week, looked at me and said, I think you need a paleontologist consult, because we might become extinct. It's unfortunate.
It's unfortunate, and that's what often happens when money speaks. And money is so loud in the healthcare industry that people don't realize it. But we're trying. If you read our book, you'll see the history of how we got here. Why it actually is dangerous to see all these people and dive into the specialty model of care. You're not living longer. You're not living better. A lot. I've heard people who say, "Well, I see all my friends. They're all seeing a million specialists. They live long. Well, they also go to the gym every day and eat really well and don't have economic stress and other things that kill people. And they happen to have good genes as well." So they make this association that they go to specialists, so therefore they're living longer. And that myth has really perpetuated itself in affluent areas, and it's and the specialists feed off it. The whole industrial complex feeds off it. So yeah, we have to. The book helps show the reality, and we're not again motivated by making money because we don't make money if people stay away from the healthcare system and to the degree that they're diving in now, we actually are not incentivized to do anything. So that's what all doctors should be, not incentivized to do anything that would make the money, just paid to see people and talk to them. That's what we should all be paid to do. And even proceduralists are who are technicians. There's some proceduralists who I don't even know why they have to go to medical school because all they do is do procedures. They could pay for procedures, but they should not be the ones deciding whether to get a procedure. It's very simple. So fixing the system would be easy. So Alan, we will continue to talk about that aspect of it. And we will continue, Alan and I, even though we're old, we'll continue providing really good care to our patients for as long as we can because there aren't that many people out there doing what we do, and it's gotten fewer and fewer and fewer. So we feel very passionate about doing what we do, even as we're attacked, like I was by the cardiologist who presented me to the board, who I recently learned also made complaints about seven other doctors in my town who are some of the best doctors I've ever worked with. So we are being attacked, and we're going to keep doing it anyway. So we are here on Sunday morning doing it. So anyway, have a great rest of the weekend.
Take care, everybody.
We will
Bye-bye.
talk next week. Bye bye.